We now discuss another component of the innate immunity. These are the molecules or soluble components, namely the complement proteins present in plasma, made primarily by the liver, although there is some synthesis by mononuclear phagocytes. And there are chemical mediators called cytokines produced by T cells, by innate lymphoid cells, and also by other mononuclear phagocytes. There is also an important class of cytokines known as interferons produced in response to viral and bacterial infections. Antibodies produced by the B cells will be discussed under the adaptive immune response. Note that each cell produces and secretes only a particular set of cytokines or inflammatory mediators. Now, what are the functions of these molecules? They function in two ways. They bind to microbes and act as opsonins, and this is to enhance phagocytosis. They also promote inflammatory responses that bring more phagocytes to sites of infection and may also directly kill microbes. Listed here are the endogenous and exogenous soluble components. We will specifically discuss complements, cytokines, and chemokines made by specific cells. These are endogenous soluble components that act locally, but note that there are also acute phase proteins produced as a systemic response to injury. You have encountered these other mediators in your previous lectures. Your lysosomal compounds, eicosanoids, platelet activating factor, and serotonin. And you also have encountered the coagulation factors and fibrinolytic system in hemostasis. The first soluble molecule that we will be discussing will be the complements. Complement system is composed of a set of 50 plus serum glycoproteins that cooperate with both the innate and adaptive immune systems. It is named as such because they complemented the effects of antibodies. Most complement components are synthesized by hepatocytes and monocytes. There are three different ways to activate the system. Number one is the classical pathway, and this is triggered by immune complexes. The first protein, C1 here, recognizes preformed IgM or IgG antibody antigen complexes, shown on the left here. Second is the mannose binding lectin pathway, triggered by complexes between bacterial mannose residues and plasmaprotein lectin, shown here on the left side of the slide. The third is the alternative or properdin pathway, triggered by contact with various viruses, bacteria, fungi, and tumor cells. In the classical pathway, antigen antibody complexes bind C1. This forms a connection between innate and adaptive immune response. Activation of this C1 leads eventually to the formation of C3 convertase, which catalyzes conversion of C3 into C3A and C3b. C5 convertase in the form of C4b2A3b is the final product of the classical pathway. There's a side entry to the pathway independent of antigen antibody complexes, and this is called the lectin pathway. C-reactive protein or CRP can also provide a side entry into this pathway by directly activating C1. The other pathway is the alternative pathway, and this is independent of antigen-antibody interactions. This forms another variant of C3 convertase. And to activate this pathway, small amounts of C3b are spontaneously hydrolyzed from C3. C3b binds to the surfaces of microorganisms and forms C3 convertase through factors D, factors B, And these are stabilized by properdine or factor P, hence the name properdine pathway. Similarly, the lectin pathway also exists here as a side entry to this alternative pathway. C3b is not formed in the classical pathway right away. So this alternative pathway is faster than the classical pathway, but it requires microbial antigens. C5a in the form of C3b C3b is ultimately produced in this pathway. So in both pathways, C3b serves as the binding site for the C5 serum protein, which is split into C5a and C5b. C5b and four complement proteins C6, C7, C8, C9 combine to form this membrane attack complex or MAC. The tubular MAC is hydrophobic, so it can insert into the membrane of the target cell, allowing free passage of small molecules, ions, and water, resulting in cell lysis. The inserting proteins are also called perforins because they form holes in the membrane. The complement proteins that are produced have several functions. The first one we have already seen. So it functions in direct microbial killing by formation of the MAC. Okay. Second is that they can help kill the organism by opsonization. So the C3b protein will function as an opsonin. So it coats the organism for eventual killing of phagocytes. So here you can see the complement receptor on the surface of the phagocyte. Thirdly, it can act as activators of the inflammatory response. So C3a can act as a chemoattractant for eosinophils. Your C5a can act as chemotactic agent for neutrophils and monocytes. Now your C3a and your C5a can also act as anaphylatoxins. So they trigger degranulation of mast cells and basophils, releasing histamine and 5-hydroxytryptamine that enhances vascular permeability and increases they also increase blood flow. The mast cells also release chemokines to cause cellular accumulation. Now the fourth is cellular activation for microbial killing. Your C3a and C5a also act on phagocytes to stimulate respiratory burst associated with phagocytosis. We will be mentioning this when we talk about phagocytosis later. And then number 5 is that they form a bridge between the innate and acquired immunity by activating B cells. We will be mentioning this also under humoral immunity later. And then lastly, it functions to clear immune complexes by cells in the liver and the spleen. And this happens through your C3b coated immune complexes. So if the C3 levels in the serum becomes low, it means to say that it is being consumed or activated. So it means to say that the complement system is being activated. This is the second molecular component that we will be discussing, the cytokines. They are structurally diverse polypeptides that function as messenger molecules. They are hormone-like molecules that act generally in a paracrine fashion and short time span to regulate immune responses. They are secreted not only by lymphocytes and macrophages, but also by endothelial cells, neurons, glial cells, and other types of cells. They have specific names. Lymphokines, if the cytokines are made by lymphocytes. Monokines, if they are produced by monocytes. Chemokines are chemoattractants made by various cells. Interleukins are made by one leukocyte and act on other leukocytes. Interferons are also cytokines made by virus-infected cells. They not only act in the paracrine fashion, they can also have autocrine action and endocrine action. They act they usually act on the cell through plasma membrane receptors as shown here. The cytokines bind with very high affinity and generally show very high specificity towards their receptors. And they usually utilize the JAK-STAT pathway as their cellular signaling pathway. So what's the role of these cytokines? They communicate signals from one cell type to another, and among other things, they can instruct the cell receiving the signal to proliferate, differentiate, secrete additional cytokines, migrate, or die. They have very significant roles in the immune system, which we will see later. This shows us the 6 families of cytokines. So we have the interleukin-1 family. This promote inflammation. Okay, and then we have um, interferon family, which is class 2. We have the tumor necrosis factor family, and then the most recently discovered is your interleukin-17 family. We also have this cytokines that serve as chemoattractants. The previous table in the previous slide showed us an overwhelming list of cytokines, but I would like you to remember only a few. And these are your interleukin-1 and interleukin-6. We will be discussing this together with your TNF later because they induce acute phase responses. So these are produced by these cells, and these are the cells on which they act, and these are their effects. Together with interleukin-1 and 6, you have this TNF-alpha or your tumor necrosis factor alpha, which we will be discussing under acute phase response. GM-CSF stands for granulocyte macrophage colony stimulating factor that stimulates hematopoiesis. Interleukin 12 and 18 are mentioned in adaptive immune response, and interleukin 10 will be mentioned under the regulation of the immune response. Other cytokines that I want you to remember will be your interferons alpha and beta, which we will be discussing in a while, and your chemokines. So specifically your interleukin 8 that we will be mentioning when we discuss about inflammation. Type 1 interferons are a large family of structurally related cytokines that mediate the early innate immune response to viral infections. It's actually a major way by which the innate immune system blocks viral infections. They are termed interferon because of their ability to interfere with viral replication. They are produced and secreted by plasmacytoid dendritic cells and virus-infected cells. After they are secreted, they bind to receptors on both virus-infected and uninfected cells. And they induce the signaling pathways that induce expression of enzymes that interfere with viral replication at these different steps. So these steps are the inhibition of protein synthesis, degradation of viral RNA, inhibition of viral gene expression, and virion assembly. Although not shown here, the type 1 interferon also increase infected cells' susceptibility to cytotoxic T lymphocyte mediated killing. This diagram shows us the interplay between cells of the immune system through a network of cytokine actions. You can see how complicated it is, so you do not have to memorize this. But what's important to remember is that we have pro-inflammatory and anti-inflammatory cytokines as shown by this balance. There should be a balance between these two groups, and certain inflammatory diseases present with characteristic cytokine profile. Therefore, in some diseases, these pro-inflammatory cytokines will have to be inhibited, while these anti-inflammatory cytokines will have to be promoted. Shown here are examples of some pro-inflammatory cytokines like your interleukin-1, interleukin-6, and your TNF or your tumor necrosis factor, and anti-inflammatory cytokines interleukin-10 and TGF-beta or transforming growth factor beta. Please remember this cytokines. Cytokine-related therapies offer promise for the treatment of certain viral infections, some immunodeficiencies, autoimmune diseases, some cancers, and transplant rejection. Here's another concept check slide to help you in your self-assessment. Here's another concept check slide that will help you in your self-assessment. This slide shows us the acute phase response stimulated by cytokines produced by innate immune cells. Within minutes after injury, the inflammatory process begins with activation of innate immune cells by microbes. This leads to the release of these pro-inflammatory cytokines, interleukin-1, interleukin-6, and TNF-alpha or your tumor necrosis factor alpha. They travel through the blood and stimulate the hepatocytes to secrete acute phase proteins, and this include your CRP, serum amyloid A, C3, C4, haptoglobin, and fibrinogen, and others. These proteins increase plasma viscosity and consequently increased ESR or your erythrocyte sedimentation rate. There is also leukocytosis caused by these cytokines. They affect the bone marrow, which promote the release of neutrophils and monocytes and other cytokines called the colony stimulating factor. Another effect is the increase in the synthesis of ACTH from the anterior pituitary and hydrocortisone from the adrenal cortex. There is also the induction of fever due to the ability of the hypothalamus to respond to elevated levels of acute phase proteins. TNF and interleukin-1 act on the hypothalamus to increase synthesis of prostaglandins. The prostaglandins stimulate the production of neurotransmitters that reset the body's steady state temperature to a higher level. The fever may also be caused by many bacterial products such as endotoxins. These are the lipopolysaccharide of gram-negative bacteria. Exposure of innate immune cells to this lipopolysaccharide causes their the release of cytokines called endogenous pyrogens. There is also the initiation of the adaptive immune response, and this is due to the migration of these dendritic cells to the lymph nodes. Acute phase proteins are proteins whose concentration is increased or decreased by at least 25% following injury. This graph shows the increase in acute phase proteins within minutes after activation of innate immune cells. Blood levels of C-reactive protein are commonly assessed, as well as ESR or your erythrocyte sedimentation rate. CRP is considered a non-specific marker of inflammation. It can therefore be used as a marker to monitor or detect significant inflammation in a person who is suspected of having an acute condition such as serious bacterial infections like sepsis, fungal infection, and measuring CRP is also useful in monitoring people with chronic inflammatory conditions to detect flare-ups or to determine if treatment is effective. Acute phase serum amyloid A proteins recruit immune cells to the inflammation site. So blood concentration of this serum amyloid A might rise up to 1,000-fold during inflammation. So they can also be used as markers in some autoimmune diseases. Effector mechanisms. Now, the two effector mechanisms under your innate immunity are inflammation. Now, inflammation is a process by which leukocytes and circulating plasma proteins are brought to the site of infection. And the main objective, of course, is to eliminate the offending agents. Okay? And after the elimination of the offending agents, then um, there should be repair. And then another effector mechanism will be the antiviral defense. And this is possible through the interferons. Inflammation comes from the Latin word inflammare, meaning to set on fire. Acute inflammation can develop in minutes to hours and last for days. It involves recruitment of cells, destruction of microbes, and repair. This is initiated by cells already present in the injured area, and these cells are called sentinel cells. These include tissue-resident macrophages, dendritic cells, Kupffer cells, and mast cells. They use TLRs and other innate PRRs to detect the invading microbes. Mast cells respond to pumps and dumps by secreting histamine and prostaglandins that cause vasodilation and increased capillary permeability, which increases blood flow through tissues and increases movement of these plasma proteins such as complements, antibodies, and antimicrobial proteins out of the blood vessels. Cytokines such as TNF, interleukin 1, interleukin 6, and chemokines are produced by these sentinel cells at the site of infection. The cytokines increase delivery of local delivery of cells by having multiple effects on capillaries, venules, and leukocytes and bone marrow. There is recruitment of large numbers of neutrophils followed by monocytes from blood into the tissues. And the cytokines also increase expression of endothelial adhesion molecules that we will be presenting later on. The cardinal signs of inflammation are dolor, rubor, calor, tumor, and functiolesa. All this can be explained by increased blood flow, elevated cellular metabolism, vasodilatation, release of soluble mediators, and extravasation of fluids that move from the blood vessels to the surrounding tissues. So, cardinal signs include pain, redness, heat, and swelling. Leukocyte recruitment into the tissues is a multi-step process. In number 1, we see the production of cytokines TNF and interleukin 1 by activated macrophages, mast cells, and other sentinel cells at the site of infection. You not only have this TNF and interleukin 1, you also have interleukin 8 and histamine. Interleukin 1 and TNF activate expression of cell adhesion molecules. So you can see them as selectin and integrin ligands on the surface of endothelial cells. In number 2, we can see that through these adhesion molecules, leukocytes attach on the surface of the blood vessels, and selectin-mediated rolling of leukocytes happen. Number 3 shows an increase in integrin affinity, and number 4 shows integrin-mediated firm attachment of leukocytes to endothelium. 3 and 4 are possible due to chemokine interleukin 8 activating leukocytes to make attachment firmer, allowing them to extravasate eventually through the endothelium and migrate towards the source of chemotactic factors such as interleukin 8, C3-5, and C3a. So we can see transmigration of leukocytes through the endothelium and migration of leukocytes to the site of infection. In addition, TNF, interleukin 1, interleukin 6 produced at inflammatory sites may enter the blood and be delivered to the bone marrow, where they work in concert with CSF or colony-stimulating factors to enhance production of leukocytes, especially neutrophils, from the bone marrow progenitors and release mature neutrophils into the blood. This way, these cytokines increase the supply of cells that can be recruited to the site of infection and replace leukocytes that are consumed during the inflammatory reaction. After the recruitment of white blood cells into the tissues, then there is phagocytosis. Phagocytosis is an active, energy-dependent process of engulfment of large particles into vesicles. Neutrophils are examples of phagocytes and also your macrophages. This process requires that phagocytes possess high affinity receptors for certain opsonins. These include antibody molecules, complement proteins, and plasmalectins. The microbes are internalized into phagosomes, which fuse with lysosomes to form phagolysosomes, where the microbes are killed by microbicidal agents. There are 3 classes of these microbicidal molecules known to be most important, and these are your ROS, or your reactive oxygen species, nitric oxide, which is a reactive nitrogen species, and then the third class is lysosomal enzymes. Another effector mechanism is the antiviral replication. Okay, we discussed a while ago under cytokines that interferon is produced by virus-infected cells, and they make other cells virus resistant. Now, patients who develop severe COVID-19 caused by the SARS-CoV-2 virus often show defects in type 1 interferon. About 10% of severely ill patients produce autoantibodies against their own type 1 interferon. So your interferon alpha is in clinical use as an antiviral agent in some forms of viral hepatitis. It's also used for treatment of some tumors, probably because it boosts your cytotoxic lymphocyte activity, or it prevents cell proliferation. While your interferon beta is used for therapy of multiple sclerosis. This slide puts them all together. So microbial invasion brings many effectors of this innate immunity into action. Entry of microbial invaders with their pathogen-associated molecular patterns are recognized by phagocytes through their PRRs. These PRR-induced reactions induce the inflammatory response, and the secretion of chemokines and cytokines and interferons and other microbials that inhibit and kill the invading pathogens. NK cells also kill these viruses. Some extracellular pathogens are also recognized by opsonins such as CRP complement components, MBL, and this opsonization enhances phagocytosis. These processes also initiate the adaptive immune response, and these actions of the adaptive immune response indicated in this box will be discussed in the subsequent parts of this lecture. This is another slide that summarizes what we have discussed. It is an overview of cells and mediators involved in acute inflammatory response. Please take a look at this slide and study its contents closely. Under normal circumstances, acute inflammation terminates itself. Chemical mediators disappear either because of their short half-lives or because they are enzymatically activated. The magnitude and duration of innate immune responses are regulated by a variety of inhibitory mechanisms that limit potential damage to tissues. We have mentioned a while ago that we have this interleukin 10. It is a cytokine produced by and inhibits activation of macrophages and dendritic cells. It it is an example of a negative feedback regulator, and it is produced also by regulatory T cells. We also mentioned about your transforming growth factor beta that inhibits inflammation. So these are anti-inflammatory cytokines. You have macrophages producing natural antagonists of interleukin 1. Another example is interleukin 17E or interleukin 25 that promotes differentiation of the anti-inflammatory T helper 2 cell subclass. Suppressors of cytokine signaling or SOCS proteins are inhibitors of the signaling pathway linked to cytokine receptors, and this is your JAK-STAT signaling pathway. So to check if we have discussed everything under innate immune system, we have discussed the recognition of microbes, the barrier mechanism, the cells of the innate immune system, like your macrophages, mast cells, dendritic cells. We also discussed about the circulating white blood cells, the granulocytes, the neutrophils, basophils, eosinophils, and then we also discussed about the monocytes and your NK cells. And we also discussed about the molecules of the innate immune system, complement, cytokines, interferons, acute phase proteins, the effector mechanisms of the innate immune system, inflammation, antiviral defense, and we discussed some ways of regulation of your innate immune system. These are the learning objectives that we have just finished. Make this your guide in studying for this lecture. I know the lecture is very long, but this will help you in studying. This is another concept check slide that will help you in self-assessment.